Elizabeth Onyango, who is a public health specialist with 25 years of experience in Kenya's Ministry of Health. She currently serves at the national level as the head of Non-Communicable Disease Prevention and Control Unit in the State Department of Medical Services. And she's also a fellow of Women Lift Health. So over to you, Dr. Elizabeth.
Thank you very much for the introduction. Can I request for my presentation to be loaded? Yes, we were asked as a division to talk about the MOH collaborations and NCD projects. And without wasting much time, that's what I'll do next. We are implementing our NCD strategic plan. It's the second one, and it has 5 key pillars. And the projects I'm going to share with you about are World Diabetes Foundation Project, Pen Plus Strategy, Changing Diabetes in Children Project, Eye Care Project, Partnership for Education of Health Professionals, Pen HIV, Amgen, CMMB. Those are many, so I'll concentrate mainly on the first one. So we launched this project in 2023 October during the World Diabetes Day, and it will run until September 2027. We have many collaborative partners in this project, but the fund holder is the Diabetes Management Information Center, that is DMI. So we are implementing 100% of interventions in 35 counties, which are shaded green, and in 12 counties, we are implementing 12% of the interventions. So this project has 3 main tracks. The first track is on governance and decentralization. The second one is on health system capacity strengthening, and lastly, advocacy, operational research. So the key deliverables for this project are as projected. 1, to equip 361 health centers, dispensaries, and a few level 4s. 2,000 health providers trained, 3,000 community health promoters trained and provided with resources, 1,600 medical interns reached through symposium, 500,000 adults screened for diabetes and hypertension, 250 health care facilities adopting the digital model, 250 health facilities utilizing digital health product and technology forecasting tool. 320,000 patients receive care for diabetes, stroke, hypertension, and then 1,805 peer educators trained, 175 peer advocates trained and supported, and 361 patient support groups established. So what is the progress so far? At national level, multi-sector engagement and NCD response financing, we have already developed an investment case on NCD financing. This is still awaiting validation. We have held advocacy meetings with the National Assembly Health Committee, the National Treasury. Then at the county level, we've also held advocacy meetings with the 47 county executive committee members of health, and then established and supported 39 county level NCD technical working groups. We have also established and supported the county NCD coordinators caucus. So under health system capacity, we have there's the strengthening of primary health care for NCD prevention and management. So what have we achieved? We have reviewed the competency-based training materials for diabetes and hypertension. We have trained 50 trainers of trainers in phase 1 counties. Those are 10 counties. We have trained 480 healthcare providers in phase 1 counties. We have held symposiums for final year medical students in Nyanza region and at Kenyatta University. So a total of 198 students have been reached. At community level, we have reviewed and updated training materials for community health providers. We have trained what we call CHAS, those are community health assistants, and community health promoters in phase 1 counties. 1,700 have been trained. We have reviewed and updated training materials for peer educators, and then we have established 109 patient support groups. Still under health system capacity, we continue to strengthen the digital health integration. So we have equipped 108 facilities with tablets to support data capture. We have whitelisted, there's the whitelisting of Safaricom lines in the kitted facilities to facilitate data capture. We have trained 1,494 healthcare providers on the SPICE, this is the digital platform, and we have linked this SPICE platform with the KHIS, that's the Kenya Health Information Software. Again, still under health system capacity, we continue to strengthen the NCD supply chain. So we have trained 35 trainers of trainers on forecasting and quantification. We have developed a digital forecasting and quantification tool for diabetes and hypertension commodities in the KEMSA LMIS, that's the Logistic Management Information System, and we have developed and deployed training materials into the MOH Virtual Academy. So under advocacy, monitoring and evaluation, research and surveillance, mainly advocacy, M&D and research, we have developed the NCD Advocacy Communication Social Mobilization Framework. This is still ongoing. We have supported the commemoration of World Diabetes Day and World Hypertension Day at both national and county levels. We have awarded support to 5 masters and 5 PhD students. And then we have conducted baseline survey across all 47 counties. We conducted M&D visits in 5 phase 1 counties and trained 60 healthcare providers on data quality and utilization. So it was important that I give you details on that particular project because for us it's a big project in the country. So these other ones, I'll just mention them because of time. So we have the PEN Plus strategy, and PEN Plus, this is a WHO regional strategy that aims to address severe NCDs at first level referral health facilities. So we have piloted this in Hamisi, in Vihiga County, and in Kina, in Isiolo County. So the objectives is just to improve quality of care, capacity of healthcare workers, essential medicines, and M&D and research. So under PEN Plus, the conditions in bold, those are the flagship conditions that must really appear whenever you are coming up with a package for PEN Plus. So those are some of the facilities that have been built through the PEN Plus project. Equipment that have been supplied. Well, I don't know how to go back. So, yeah, human resource capacity. So next steps, we want to expand this project to 6 additional counties in the country. Then we have another project of changing diabetes in children in Kenya. This is a global initiative and steered locally by the Ministry of Health, and the, DMI and Novo Nordisk have been at the center of it, with support coming from Novo Nordisk and DMI implementing and also being the fund holder. So it was launched in Kenya in 2011, and there is to enhance integration of type 1 diabetes into the healthcare system. So those are the components of the CDIC project. That is infrastructure and equipment improvement, training. They provide free insulin to type 1 diabetes. There's patient education, diabetes registry monitoring, and learning outcomes. So we are already in 39 counties, 51 sites in 39 counties. We intend to reach the remaining 8 counties by June 2025. Now we have another one that is eye care, and I care basically is an acronym for I is I, myself, you, we, and then C for capacity, A, affordability, R, reach, and E, empowerment. So we want to build capacity of healthcare providers, which we continue to build, and the affordability so that insulin can become more affordable, and strengthening to the supply chain so that this insulin and other commodities are able to reach those who deserve, and empowerment, just to empower patients to be able to manage their condition. This is supported again by Novo Nordisk. We have another project that is the Pain HIV. This is a project that we are undertaking together with the NASCOP. It's supported by the Global Fund, and the purpose is just to integrate NCD and HIV management, just to enhance care for patients who have HIV and also have NCDs. Unfortunately, we were to do the baseline survey, and we've been informed funds have been cut. Yeah, you know what's happening globally. So we've been affected, and that project, we are not sure, it's still hanging in the balance. Now, the other project is the Partnership for Education of Health Professionals. This one is now supported by Novo Nordisk Foundation. You know, we have Novo Nordisk Foundation. And it's basically to build institutional capacity through online and blended learning. In addition, just to enhance collaborative alliances for cardiometabolic disease education at middle level institutions. So the implementing partners, apart from MOH, is AMREF, CHAC, KCCB, and APHRC. So we are targeting clinic officers, nurses, nutritionists, pharmaceutical technologies, lab technologies, community health assistants. So this one is a project that will be there for quite a while. Then we have another one on food environment policies. This one being spearheaded by the Division of Nutrition at the State Department of Public Health, and we are collaborating with a number of government ministries like Ministry of Trade, Agriculture, Education, and so far we want to improve the food environment so that it encourages consumption of healthy foods and to discourage consumption of unhealthy foods. So we've already developed the Kenya's nutrient profile model, which will be launched any time from today, soon. And with this, it will guide us in coming up with 4 key policies and regulations. The first one is on restriction on marketing of unhealthy foods and alcoholic beverages to children. Again, another physical policy for diet, in particular, taxation of unhealthy foods, reduction of taxes on healthy foods, and subsidies for healthy foods. Another one is nutrition labeling, including front-of-pack labeling to inform consumers on healthiness of food, and then public procurement policies so that it can enhance provision of healthy foods in public institutions like schools, prisons, and hospitals. Another project is by PATH, that's called Amgen. This one is in 2 counties, Makueni and Nyeri. And basically is to build capacity of healthcare providers on cardiometabolic conditions, to provide support for people living with these conditions, and to improve service delivery data, and also to strengthen supply chain. Then we have another one this one is an upcoming project, CMMB. They've done baseline survey. It's to improve the medicine component of diabetes and hypertension, because we're doing everything right, but we're having challenges with medicine. So the component medicine access, supply chain strengthening, and data management. So they are reaching 10 counties, and those are some of the expected outcomes. So we continue again to collaborate with professional bodies like KDSG, PESC, Kenya Revenue Authority, Kenya Renal Association, at least you're awake, Kenya Cardiac Societies. So areas of collaboration are as indicated there, so reviewing of guidelines, and we really appreciate this professional association. They bring the expertise that we might really need at the national level. Yeah, so in conclusion, I can say strong partnerships are key to addressing the growing burden of NCDs, and collaboration between the Ministry of Health and stakeholders will enhance resource mobilization, which we really need, policy implementation, community engagement. Let's strengthen our collaboration to accelerate progress towards national and global NCD targets. Thank you.
Thank you very much, Elizabeth, for just that outline of all the work that's going on. I think before we have our chief guest give his address, this would not be complete without the executive director of the NCD Alliance Kenya just giving us, I asked her to tell us 3 things that she feels have been an achievement in this decade. So I want to introduce Dr. Catherine Karekezi, who is a pharmacist by training, but has a PhD in medicinal chemistry. She's the current executive director of NCD Alliance Kenya, which is a body that we are all a part of. So KDSG is a body that is a part of NCDAC, and they represent us at different regional, global forums. She's been instrumental in advocacy and in the NCD development in this country. She's a very soft-spoken person, but does her work very efficiently, and I just want to welcome her. She's passionate about empowering people to better themselves. That's her passion, and she's been on the DMI board, which Nancy heads for very many years. Thank you, and welcome, Catherine, with just the 3 things that you feel you have achieved.
So thank you very much, Dr. Kunyiha. Good afternoon, everyone. Our chief guest and our colleagues. 3 things over 10 years. I think, at least for us as NCD Alliance, the first is developing the advocacy agenda of persons living with NCDs in Kenya. So this is a document which basically guides the work that we do in terms of advocacy. The second one is a recognition of meaningful involvement of persons with the lived experience of NCDs to ensure that people living with non-communicable diseases are actually invited to sit at the table in terms of policy development, in terms of implementation, and even in terms of monitoring and evaluation. So basically for them to come and give their views and to address the government and us in terms of what they need, because we need to remember that these individuals, these people, a person living with a non-communicable disease lives with that condition 24 hours in the day, 7 days in a week, 30 days in a month, and 365 days in a year. So really they know about the condition, and they are the experts of the condition that they live with. I think the last one is really establishing county chapters of persons with lived experience in the different counties that we work in. At the moment, we're in, I think we're 21 counties in Kenya. And these county chapters are actually composed of individuals, either youth, members of the younger generation, even older generation, not necessarily living with a non-communicable disease. They could be caregivers, but they're individuals who have committed themselves to contribute to NCD prevention and control by getting involved in advocacy. They've been able to advocate to their county governments in terms of the challenges that persons living with NCDs face, and also submitting their proposals, and various counties have been responsive and are actually listening to the community in terms of what they need to do in the space of non-communicable diseases. So thank you very much, Dr. Kunyiha.
Catherine always has a scientist's precision. Thank you. Thank you for summarizing all that you do in a few minutes. So finally, we would like to invite our chief guest. Congratulations on your recent appointment. And today I'll just share a few things about you that you may not know that I know about you. Dr. Fredrick Oluga is a physician who trained in Moi. And in 2009, he ran the first medical students conference. So that is many decades, so International Medical Students Conference. He has been secretary of the KMPDU. He has been DMS of the Nairobi Metropolitan. He's a key advocate, and I think this is what a lot of us know him for the advocacy of conditions for healthcare practitioners. And that's for all of us here. And that is appreciated, I think, as part of your life story. He loves the Subaru brand. He enjoys reading, and reading politics also, so I'm hoping you will be able to serve us with all that wisdom in your new tenure. And he enjoys a good steak, as well as a good political book. So I think here to address us today is a doctor, a physician. It's an honor that he has been given this position in health, in ministry, in the recognition of all that he has done. And as a society, I think it's exciting to see healthcare professionals in these spaces that sometimes we have challenges engaging with. So without further ado, I want to welcome Dr. Fredrick Oluga to the stage to give us his address for our 10th celebration.
Thank you. Thank you. Have your seats, please. Yeah, I know Dr. Mbui sold me out. Yeah, and he will pay for it. So, yeah, because I'm not so sure how many of you know my name, Fredrick. Yeah, if you are looking for Fredrick, that's not me. I am Fredrick Oluga. Yeah, but I'm glad to be here, first because of the nature of this group. You know, when I had diabetes, Kenya Diabetes Study Group, and I've asked this question before, I think maybe Dr. Hilda Nabiswa is no longer here, but I asked her this question a year ago. Diabetes Study Group. There was a time there was this discussion around the finance bill last year, which brought a lot of issues. And part of the controversies was on whether bread should be taxed or not. And I asked, what does the Kenya Diabetes Study Group say about it? And you kept quiet. You never said anything about it. Today you have called me here to celebrate 10 years of your existence. And that is quite an achievement, just to reach 10 years. But I don't think that I have very good news for you, because you called me to read a speech, which I don't think I will read. I think I will speak from my heart. And when I speak from my heart, from previous experiences, sometimes it's not very nice, especially if you're the one receiving what I am saying. Yeah, usually it's nice when I'm on the other side and somebody else is receiving what I'm saying. So I wanted to ask, now that you've called me, and I think Dr. Priska Mungla, I also asked her, what do you want me to come and do? Yeah, what did you want me to come out with from here? Because I don't think it's fair for you, for me to come and read a speech. Elizabeth, who is our officer at the Ministry of Health, has already told you a number of things. So it's way more important for you to tell me what you want me to do. But I'll tell it to you. One is that you don't have any report that I can go and implement. So you have not used your time well. You have not used my presence here well. Yeah, because you want me to go and figure it out for myself, the cost of insulin, the cost of the diabetic medicines, the access programs. You want me to go and think for you, but you are the study group. Number two is that I have not seen the research that should inform our policies that you're telling me. I know that you're talking about the unreached population, around 54% of the persons with diabetes who are still undiagnosed. I know you're talking about just around 20% of all our diabetic patients have what would be considered some level of comprehensive care. I know that we are talking about a lot of challenges when it comes to financing of diabetes care. But what exactly is the evidence that should inform our policy? That should come from you, and I am not going back with it. So your assignment is not done. I want to talk about very few issues that relate to that, and really what has been presented, and perhaps what you have discussed. This appointment and my position is really for you. It's not for me. And it's for you because I am your product. I think you are the people who pushed me in the forefront. You put me there to speak on your behalf. I spoke on your behalf. I got the opportunity to learn about healthcare. And I am extremely passionate about healthcare. I think that cannot be oversaid. I'm very passionate about system performance, systems that work, and especially systems that work for people who don't know who to call, who don't know anyone, who don't know the MCA, they don't know the MP, they don't know a sister or a brother who is a nurse, they don't know somebody who can call somebody in a hospital. Today, our country has become a big challenge when it comes to healthcare access, not because the healthcare services do not exist, but because of the trust and the confidence in the healthcare system. And every time a Kenyan is going to seek care, they are extremely worried. I know a number of you, even as you sit here, on your WhatsApp or on your SMSs or even phone calls, somebody has called you to ask for the doctor or the nurse or the hospital they should go to. True or false? That is a mess. Because you can imagine the number of people who don't know you. You can imagine our brothers and sisters who don't have somebody they can call. And that's really the work that we have to fix. And that's not my work. It's your work. It's your work because you have to tell me three things. You have to tell me what to fix. You have to tell me how to fix it. And you have to tell me when it can be fixed. But you have to tell it within the policy of the government. And so I give you two assignments. One assignment is that you should go back and read the legal framework for our healthcare system. Start from the Constitution, Article 43. What does it talk about? Go to we have now 19 pieces of legislation, the acts of parliament that have been passed, from the Health Act, the Public Health Act, all of the regulatory acts, the legal notices that we have. Read it. See, you are the study group. Haba mbadilishe hiyo jina. Okay? Read all those 19 pieces of legislation. The Ministry of Health currently has 66 policies that somehow govern our healthcare sector. Read all those 66 policies. Okay? Come down to some of the instruments of implementation, which are only two. One is the guidelines. I'm sure you have the guidelines for treatment of diabetes. And then, of course, the protocols that we produce from time to time. I know those ones you are extremely familiar with. But the three, from the constitutional framework to the legal framework to the policy environment, that is work that you have to do. And once you have read them, just come out with two things. One is, do you have opportunity to ride on that legislative framework to sort out the problems that we need to sort out? this 54% of the unreached population, how do you work with that legislative framework to sort it out? This 20% or 80% that are not having comprehensive care when it comes to diabetes, how do we sort it out? Those are the things that you should be telling us. So if your work is simply at the level of a study group, your work is not just to study on septagliptin, and especially when you call me here, because I sign on resources and the prioritization of things that are important for the health sector. And I'm going to talk about that in a moment. And I said this position is for you. It's for the health sector. It's not for me. So you have been entrusted to sort out the problems that we have never been able to sort out for a long time. So if you don't sort it out now, forever keep silent. And I'll say that a second time. If you don't sort it out now, forever keep. But there's something we must do to sort it out. Number one, we must understand the context of our healthcare system. You must understand the healthcare system. Many of us are very competent in our domains, professional domains. We can mention all the molecules, the new ones, the old ones, the ones that have been outdated, the ones that are still under study, from A to Z. All right? Just that you cannot link it with how such a molecule can find its way to Turkana. You must understand the healthcare system. Now, the healthcare system has only three functions. Any healthcare system. One is to promote health. That is, people must be healthier than they are. So if a healthcare system is not improving the health, then it's not performing its function. And this is measured on the lifespan. So if a healthcare system is not improving the lifespan of the population, then it's not performing its function. Of course, that is determined by a lot of other social factors, which the WHO calls the social determinants of health, which I know many of you public health practitioners know. You know about the road issues, you know about education, you know about poverty, you know about information systems, you know about water and sanitation, you know about housing conditions, which of course determine the disease profile and the disease burden. Number two is that our healthcare system must protect people from getting diseases. Diabetes is one of them. And you've talked about the whole diabetes value chain, from prevention to screening to diagnosis to treatment, rehabilitations, referral. So you must understand that healthcare system. In that context, certainly there are platforms that the Ministry of Health has already created. For example, we have the CHP network. We already have 107,000 community health promoters. At the beginning, there may have been a bit of a challenge, perhaps tensions between these community health promoters and the professional health workers. You know, and I think at some point, people thought that they are being replaced and they are being pushed out. It is also your responsibility to look at how do we have an integrated way of guiding their work so that we maximize on their performance, but more importantly, we maximize on the prevention of disease, including diabetes. And on that, there's something we call impact pathways. So you must come up with an impact pathway. Across that value chain, what's the impact pathway for prevention? What's the impact pathway for screening? What's the impact pathway for diagnosis? What's the impact pathway for treatment, for rehabilitation, for those of our colleagues that already have suffered organ damage, guys who have gone through amputations and such? We must come up with those impact pathways. We must come up with an impact pathway for referral. When somebody has been diagnosed or is suspected to have diabetes at a lower level facility where the skill may not exist or the product that needs to treat them does not exist, how does that person move within the healthcare system? You must come up with that. I was still about the context analysis of our healthcare system. And the second thing around it is the financing of the healthcare system. Somebody has talked about politics. There's something we call the political economy, because politics determines the distribution of resources. So however much you are in the wards, politics will determine how much money you have in that ward to treat that patient, and you can't run away from it. But there's a way in which we can engage, and that's why I was talking about the evidence. And when you talk about political economy, you only have two things to describe in a language that we who determine resources and the people that we talk to, Parliament, the National Treasury, can understand. And those are only two things. One is the economic burden. So you must simplify the economic burden of diabetes, because you are the people on the ground. When you give us that evidence in a way that is not refutable, take it to the bank, it will be implemented. So how then do we do this? I have had the opportunity to speak to, the other day I was with the Kenya Renal Nurses Association, and I gave them a promise, and that promise I'll give it to you. We want to help you, and we want to help all the associations. Because of this struggle to speak a language that can be understood and to simplify the things that need doing. The things that need doing is what we call prioritization. Because our healthcare system has a lot of problems. Tomorrow, when I'm talking to the obstetricians and gynecologists, they'll be talking about maternal mortality, which has remained somewhat a shame. And we have decided we must work on it. Today, you're talking to me about the inputs that are lacking for diabetic care. The following day, the renal physicians will be coming about what they want to be done to streamline diabetes. Dialysis and transplant services. And that is just 3 organizations. We have 29 of you in the sector. Okay? So that we are all not shouting, we are going to establish a health policy platform. And that health policy platform will be a very safe space for all of us. The Kenya Diabetic Study Group can come and publish its reports. And I've mentioned it must speak to the economic burden, the social impact. It must speak to the context of the healthcare system. I hope you have understood me. So that everyone can look at it. Because there are 2 things that we must do. In our prioritization journey, we must determine, number 1, what is it that if we do, gives us the highest dividend. And I'll give you an example. I happen to have been privileged to lead Nairobi healthcare system, where we did quite a lot of work. And I sneaked into some of the hospital management team meetings. And in that team, there's everyone. There's the nurse, there's the physiotherapist, there's all these guys. And sometimes you find somebody in the corner, an ophthalmologist there. You find an ENT surgeon somewhere in the corner. Often, many of you health professionals don't attend those meetings because you think that those meetings don't have a lot of value. But you want to link the decisions that you have in the ward, the lack of insulin, to somebody else other than yourself. Those meetings are important, but I'll tell you my experience. My experience was that those meetings were often degenerating into disagreements because either the medical superintendent or the in charge of the hospital would be seen to be favoring one department. For example, many of our hospitals, and you know a large part of the services we provide are reproductive health services. And sometimes because of the audits that are related to it, sometimes because of, the measures, the measure of the maternal mortality that are related to it, often people will incline resources towards that. But then we don't make change. So the maternal mortality for this year is the same as the maternal mortality for the next year, and is the same as the maternal mortality for the following year, but we keep giving resources. So something surely is not right. So my experience in Nairobi was that it was always a struggle for resources. And you give resources, but those resources are not enough. So however much you favor them, those resources are not enough. But then we realized, for example, that if we supported the ophthalmologists, at that time NHIF was reimbursing 30,000 shillings for every cataract surgery, they would be able to generate 900,000 shillings per day. If you multiply that by 20 days of working, you can see the amount of money. It's around 18 million. That money per month was enough to sort out the problems of the gynecologists. That's the challenge I'm giving you. That all of us must look at what is it that if we do, we sort out the problems of insulin. That solution may be with you. That solution may not be with you. And this is what we want to do, to bring everyone together so that we unpack healthcare and we discuss it from a point of clarity. And we all agree that if we invest in A, it will solve A, B, C, and D. Am I speaking? This is the assignment that you have. And so soon we will begin to invite some of these ideas. And those ideas must be very innovative. Those ideas must be extremely innovative because we don't want you to be Kodak. You know, Kodak said that we didn't do anything wrong, but you collapsed. And for us, the associations, because I am part of you, and you know I can speak to you without blinking. This is our story. Continuously we have lost the grip, we've lost the decision, we've lost the power, we've lost the policy. But then we are in our corner. We didn't do anything wrong. We are pointing fingers. Now is your opportunity, a second chance. Use it or forever keep silent. I want to thank the many people and the many institutions that have helped us in this journey. As bleak as our situations are, I think we've made a lot of progress. A lot of progress. And I think a lot of programs were mentioned to you here. The challenge I also have on that, and which we have discussed with the Cabinet Secretary this morning, is whether we can consolidate some of these projects and programs. Sometimes we think we don't have money, but then the money is split in several multiple things that then do not give it visibility and do not give that money impact or value. And so this is something that we are placing to you, but we will also place it to the development partners and the donor community as we are speaking to you, because they also come with what we call split conditions. So they want to finance something and they have some conditions. And I think we are getting to the table. We are getting to the table on how we can reprogram or consolidate. Again, that will be driven by what you think should be done, by how you think it should be done, and by when you think it can be done. So that we consolidate and come up with a serious comprehensive program that reaches every single Kenyan who is either undiagnosed or is already living with diabetes. And I want to challenge you, because amongst you are serious scientists, and you will forgive me a bit for saying this, but I would like to push it back a bit. If you guys sat amongst yourselves, I think you can come up with something really nice, a proposal, something beautiful, something that captures the country, something that I can put my hand on and go and defend, something that the president can look at, and when he's talking at the United Nations General Assembly or speaking to a donor, we can put money on. Something that is 7-10-year program, a bit sustainable. Serious money, not small money. I hope you understand. That captures access to medicines, that captures the issues around prevention, whether it's education or whether it's the support for our community health promoters, that captures research and development, that captures the clinical trials that I know some of you are already doing, but in a proper way, because we all have all these molecules coming. We all can't afford them. Am I right? We all can't afford them. Our patients can't afford them. We all have a very restricted resource envelope. So that we put a serious program for diabetes. And I know you scientists can do it if you work together and if you put your heads together. We don't want to waste this time. We want to be very innovative so that you don't say that we didn't do anything wrong, but you collapsed like Kodak. And related to that is our healthcare financing. As you're aware, we have overhauled the mechanism for financing healthcare. The Social Health Authority. I hope that everyone in this room is registered, but by virtue of the fact that you're employees, I hope you are registered, and you have put in your dependents there. Because everyone in this room has some form of income. That's something that we have to make work, because we have no option. The Social Health Insurance Act established the Social Health Authority. So for those of us that have been wishing that we are going back, there's no going back. In there are 3 funds. One is a primary healthcare fund. That's a tax fund. Tax fund means that you pay your taxes, whether they are pay as you earn or when you buy mandazi or vertible goods. It goes to the national consolidated funds and it's appropriated by parliament. So that's a tax fund that every Kenyan should benefit from, the primary healthcare fund. It's supposed to cover all primary healthcare services. And I know for sure that diabetes is also among some of the conditions that we are pushing to the primary healthcare level, especially screening, prevention, and a bit of diagnosis. I know that our community health promoter kits have a glucometer. We need to look at how to ensure that they are calibrated, they are quality, they have batteries, they have the sticks, glucose sticks, so that then we can assist both in the screening and the diagnosis at that level. All those are primary health care issues, which every Kenyan can enjoy at level 2 and at level 3, and in some level 4 facilities, particularly the public health facilities. And because we have distribution of public health facilities and select faith-based facilities, we can work with you because you're on the ground to ensure that people access these things. So when you are in a county government, as a study group, you should also be giving us feedback of where this is not happening, so that we don't just sit and think that things are happening, but they are not happening. Because we want to make sure that the performance of the healthcare system is in tandem with the healthcare financing. So on the primary healthcare fund, there are specific services, which we call primary healthcare services, which we want you to help us monitor and provide feedback so that we can improve them and we can improve that access. Sometimes, because people haven't been reached with the right information, they don't have access to these things. And we are relying on you to make sure that this information gets to every single Kenyan, that they can now get diabetic prevention, they can get diabetic screening, they can get diabetic diagnosis in every level 2, every level 3, whether they are public or private, and in all level 4 hospitals that are public, and in select faith-based facilities. The second fund is also a tax fund. It's called the Emergency, Chronic and Critical Illness Fund. It's from that fund that we have already announced the benefit package for cancer, having improved up to 550,000 per year. And also the ICU rebates that were previously 4,000, now they are at 28,000. But there's more that can be done. I know that we've discussed with your chair and leadership some of the challenges that you have put across, especially around medication for diabetes. And I think those are under consideration. I would appeal to you to speak to the benefit package panel that we have instituted, led by Professor Jaoko. Again, the decision has been brought back to your hands. And you will have to determine what is it that is useful to be paid. So far, we've talked about ICU, we've talked about cancer. In that resource context, healthcare financing, you must bring everybody on board. The renal physicians will be talking about dialysis. The orthopedic surgeons will be talking about knee replacement. The cardiac surgeons will be talking about cardiac surgeries, open heart. Everyone will be speaking. But it is also upon you to determine, where do we start? How do we progress? What do we do now? What do we do tomorrow? And how do we do it? The benefits package panel has been instituted, gazetted. So please have a conversation with Professor Jaoko. The decision is in your hands. I want to finish by talking about the Ministry of Health and the mandate of the Ministry of Health. Our work is to do policies and to ensure that we have a standard environment for practice. That standard environment is both professional environment and also providers. That is the hospitals, the clinics. But in that, we want to create a bit of order because there's a bit of disorder in the sector. Ama hii disorder iko tu pande yetu peke yake. There's a bit of disorder in the sector where everyone is law unto themselves. Where people do things that are not within the law, they are not within any policy, they are not regulated. And we want you to help us in bringing this order. Because it is this order that will also restore public trust and confidence. Public trust and confidence will help you. It may also be very facilitative, but we want you to support us because you're the one who need to determine the environment that makes provision of care safe for your patients and the practice of medicine fulfilling for you. Because without those two parameters, that's the people who consume our services and the people who give it, that is you, every single policy, every single standard that we make at the Ministry of Health is ineffective. And this is the collaborative approach that we are taking, part of what we discussed. And so today, my work here was to come and give you an assignment, because you didn't give me any. You didn't give me any assignment. So I've given you my assignment. But soon you will be hearing from us. We want you to be very proactive. We want you to be very innovative. We want you to be very supportive. The benefits package that we have right now under the Social Health Authority is not cast on stone. It's the responsibility of the Cabinet Secretary to review it from time to time. The Cabinet Secretary relies on evidence. That evidence will be brought by the panel that has been gazetted. That panel must speak to you. And you must speak to the economic issues, the social issues, and the health system's context. And talking about that, and I wanted to finish with another mandate of the ministry in terms of supporting you to provide, to get resources, whether those resources are partner-driven. That's why I was talking to you to bring some good proposals that we then can support, because when it becomes a government agenda, then you know it has a higher scale of being supported. I wanted to speak about the context of our funding. We are not America, we are not China, we are Kenya. And so Kenya has a very strong economy. Kenya has a lot of opportunities, but we must look at things from that perspective. We must look at what exactly can we afford, what exactly can we not afford. And we open it up in this our discussion so that the decisions that we make are decisions that are consensus-based, and remember I've used the word consensus-based, and are also evidence-based, because evidence is context-specific. Evidence is not just about what people do in America. For example, on the vaccination front, the good nation of Netherlands does not give rotavirus vaccine. Here in Kenya we do. You know why they don't give it? Because for the last 15 years, there is no single child that has died of diarrhea in that country. Not that they don't have it, but they have never had anyone die of diarrhea. So what is our context? So something may be happening in America as far as diabetes management and treatment is concerned. But must we also do the same thing here? You give me the answer. With those very many remarks, I want to thank you so much for inviting me today. I promise to support you, to facilitate you, and I ask the same of you. Be blessed. And congratulations for your 10 years.
Thank you very much. And because we are about to go for lunch, I'll ask us just to stay standing, okay? Then we'll go for lunch. Thank you very much for the challenging insights. I will ask for your email so that I can send you our 2023, just a report we had put down. And one of the things is so that you can advise us probably about language, because a lot of these matters have been talked about. We have fought a lot for the tax, especially like on strips. Insulin is not taxed, but strips somehow are, so we are